Welcome to The Code, your guide to health and human performance. I'm your host, Dr. Andrew Fix from Physio Room, a performance-based rehab facility here in Denver. On this podcast, we're going to explore the key areas of your life that impact your overall health and wellness, from sleep hygiene and stress management to nutrition, movement, relationships, and more. We bring you conversations with industry experts and top performers to share strategies they have for cracking the code on health and human performance. Now let's get to today's show. What's going on, guys? Dr. Andrew Fix back for an episode of The Code. Thank you so much for joining us. Thank you for tuning in. We appreciate all of your time listening to this, however you might be consuming this podcast. This is going to be really fun. I've got 3 of my coworkers here from Physio Room joining me. We're going to spend some time talking all about ACL tears, ACL reconstruction. We've got some experts on that here on the show. So without any further ado, Dr. Allie Nelson, would you do us a favor and just introduce yourself for all the listeners to hear? You're newer to our team here at Physio Room, but who are you? Where are you from? And tell us a little bit about you.
Yeah, so I'm originally from North Dakota. All my schooling is from there, undergrad as well as PT school. And after I graduated, I knew I wanted to continue learning more. So I did an orthopedic residency program here in Denver to become an orthopedic clinical specialist. And basically, I've been here ever since.
Awesome. Well, we are so stoked to have you part of our team. I'm pumped to have you on this podcast. So thanks for carving out some time to do this. And I'm excited to ask you some questions. So just like Allie said, she is an orthopedic clinical specialist. Dr. Tim Tracy is as well. Tim, can you do us a favor, introduce yourself a little bit? You've been with our team a bit longer, and I know we call you the bike guy a lot of times, but tell us about you, Tim.
Yeah, so before I really started focusing on cycling, the first 8 years after graduating PT school, I worked at the University of Missouri. It was a big orthopedic complex, and so I saw a lot of post-operative patients. A lot of them were ACLs, knee injuries. Worked with the D1 athletes from the zoo. After doing that for a number of years, then I worked with my alma mater, the Columbia College soccer team, and worked on a off-season injury mitigation program with them. And then also worked with any other athletes as well that were having knee issues or post-operative status. So it's something that I've seen a lot playing college soccer, and then really one of my most passionate things to know about, just having that experience.
Yeah. And like you said, you've seen it a lot. Unfortunately, in the clinic, it is very common. And speaking of which, James, as you briefly introduce yourself again, some of you guys listening to this may recognize the name James Stetson. He's been on this show a few times before, but James has also had his own experience with an ACL tear and reconstruction. So let's hear it, James.
Yeah. So James Stetson, you guys know me as the crappy chiropractor. I mostly have most of my experience in ACLs on a personal side, tearing my ACL in 2020, and then ultimately turning that into a trip to the CrossFit Games about a year and a half later. So been there, done that, as they say.
Well, and if this is cool with you guys, this is where I would love to start. Tim, you obviously mentioned that ACL tears are really common in soccer, but James, you've had your own experience. So could you sort of paint that story or, rehash that story of how did you tear your ACL? And then what was your experience like, having that injury, having the surgery, and going through that rehabilitation process for yourself a little over, 2 years ago?
Yeah. So it's funny that Tim's seen most of his ACLs in soccer because I tore mine playing soccer. Indoor soccer, just basically was airborne, took a wrong step as I landed because I got pushed off balance and tore the ACL right then and there. I had surgery about 2 months after the fact, give or take a handful of days. And that was right before COVID ultimately hit, which gave me the ability to really focus on, pre-op a little bit, but mainly post-op. I have a pretty awesome home gym facility in Kansas City where I was at the time, and kind of got the ability to work out as much as I possibly wanted to. After that reconstruction, I took about 6 days off completely where I didn't do any kind of movement. And then I, as somebody who does CrossFit, got into doing CrossFit style workouts. In addition to my rehab, I really leaned on the crossover effect in training. So a lot of lower body stuff, but mainly with my left leg in order to continue to hopefully hold on to some strength on the right side. Mm-hmm. But my ACL experience was a little bit different than hopefully most will be, because I also tore the lateral horn of my meniscus on the posterior side, which meant that I was non-weight bearing for 6 weeks, which made my recovery a little bit more challenging than most. And so I had to relearn to walk a little bit at the end of those 6 weeks. So mine was a little bit more fun per se than the average experience. But for the most part, hitting the same milestones in the end, doing roughly the same things. And I actually at one point tracked everything that I did and built I call it the crutch program. So a program of everything that I did training wise post-op.
Yeah. Well, and you kind of mentioned it, that sort of crossover effect. I was just having that same conversation with somebody here in our clinic earlier this week about how, and I know you three do this, but whenever we have someone in the office, if we have them doing exercises, say for their left leg, we're also going to have them do them typically on the opposite side, because there is a huge neurological and physiological benefit from whether we're talking about muscle gain and growth, reduction of atrophy, whatever that might be, to training the opposite side of the body. So, and then, being out here in Colorado, we mentioned soccer, we're starting to slowly creep towards ski season and everything. And ACL tears are just really, really prevalent, particularly in different parts of the country, depending on what's going on. So, Allie, what about you? James said he started rehab, he had the surgery 2 months after his tear happened. What have you seen in the clinic typically is the timeline when someone tears their ACL? How long is it before they then have surgery? And then post-surgery, how quickly do they usually get to you in the office?
It really depends. My sister, actually, she just recently tore her ACL. So I've been going through this whole process with her. But as soon as they tear their ACL, it's basically the matter of when they can get in for surgery. You want to get them in as quick as they can, especially if they're athletes. And then from following up from that, it depends on how far out they are. I definitely encourage prehab prior to, if it is going to be more of a delayed surgery, because the carryover effect, especially with quad activation, getting their quads firing right after surgery can be super challenging. So if they can get in before that, I definitely recommend it. And then I will see them usually right away, right after post-op, they'll get in with me.
Mm-hmm. Yeah, usually within days, I would imagine. Now, Allie, I know all of us on here know what you mean when you say prehab, but so say someone's in James's situation, they have the injury happen, but they're not going to be able to get in for surgery for a month or 2 months. And you're suggesting that they start participating in prehab. What exactly does that mean?
So basically it's looking at different things that we would look at after they have surgery. So you're kind of coming in and getting a foundation of what the strengthening is going to look like. And because they have the swelling right after surgery, that inhibits and stops the muscles from working appropriately. So if they can get in prior to having surgery, we can basically help them and guide them through exercises so they have kind of that knowledge base prior to and know what they should be feeling because of what's going to happen with pain and swelling after surgery.
Yeah, I love that. And that can be extremely beneficial, speed up that recovery process oftentimes post-operatively. And, I think it's interesting that I recorded an episode as of the recording of this, August 25th of 2022. This episode I'm about to reference hasn't aired yet, but we did an episode on, the RICE principle. And I just thought it was great that you didn't mention people were coming in and you were just slapping ice packs on their knee to reduce that swelling. You talked much more about movement and exercise and getting them moving, seeing how you can minimize those things and get them prepped. Okay. So someone goes in and has that operation done. James, what type of graft or whatnot did you have in your surgery?
Yeah, so I did a lot of my own research going into my surgery. This is before I graduated school, so I wasn't, a know-it-all yet. Not that I am now, but my surgeon recommended the patellar tendon graft as kind of his personal preference on, what I wanted to do post-op, continuing to do CrossFit at a relatively high level. I don't think he understood what exactly I was talking about when I said that. But that's pretty typical. But then there's other options being cadaver, either a cadaver ACL or a cadaver Achilles tendon is actually what I've heard is a new one. And then your own hamstring. I ruled out hamstring pretty darn quick and cadaver ACL pretty darn quick as well. I've heard and read really good things about cadaver Achilles tendons just because they are under crazy load all the time. But I like the idea of just using my own tissue, even though that quad tendon can be more painful of a recovery, which it definitely wasn't easy. I've had really good results with mine, and I've been real happy with it so far.
Yeah. Thanks for that. Tim, since you've had, it sounds like quite a bit of experience working with people, especially there from Mizzou and whatnot, who have torn their ACL. And I know this is very surgeon dependent and maybe region dependent, but what have you seen is pretty common in terms of, trends of what types of grafts or repair types people have for this procedure? And then what I would love to do after that is sort of go down the path after we talk about grafts of like that decision-making process with Allie of whether someone should or should not have a surgery depending on their situation. Like, do we handle this operatively or not? But first, Tim, what have you seen with the grafts?
Kind of like what James mentioned. So the high level patients, people want to get back to their prior level of function, then the patellar graft is definitely shown to be a favor in that regard. Then as far as the quad tendon repair has also been a trend lately that I saw just as much. And that was also just kind of a physician preference based on their training as well. So definitely like those higher populations, that's what is most common.
Yeah. That makes sense. And I'm right there with you, James. If you are somebody who is, really trying to get back to a higher level activity, this is a younger person who really hopes to be pretty active. A lot of times there is an opt-in for using your own tissue in that type of a situation. Whereas maybe a little bit different if this is someone who's a little bit older, they're looking for an enhancement in stability, but their activity level is not going to be quite what yours is based on that frame we see sitting there behind you. But Allie, what types of conversations have you had with clients or training in your residency program about like when, and you sort of already mentioned this, if they're going into surgery, the quicker the better if they're going to have that done. But like, what are some situations where this person probably is definitely a candidate where they should go have this reconstruction done versus some conversations where maybe we end up recommending to them or you do, maybe you don't need an ACL reconstruction surgery in this unique situation?
Had patients that are generally older and they have either torn their ACL a while ago and they didn't realize it. And now it's years later and they have knee pain. And they're like, oh, hey, I did this, but I don't really know when, nothing significantly happened. Then with that, I would treat them a lot differently than I would my younger active patient population. So if I have a young athlete that comes into me, I'm going to recommend surgery basically for them because similar to James, they're going to want to get back to whatever it is they're doing in the sport. So they need that stability and that foundation. However, if they are older, then it's kind of more or less what they're going to return to doing, as well as the chronicity. Did it just immediately happen? Or was it something that happened years ago and now they're just starting to have knee pain?
Yeah. And I know sometimes we get into conversations where, whether, we would classify someone as a coper or a non-coper, before or after their surgery happens, like our perception based on what we're receiving from that person of like how likely they are to be successful, how likely their recovery process is to go. Can you touch on that just a little bit?
Yeah, for sure. So definitely the classification between the two of what you're kind of looking at is to be a coper, they have to have no more than one episode of giving away since the injury. They also have to be able to do a single leg hop test. There's multiple variations of it, but basically the injured leg has to be at least 80% of what the uninjured leg is.
Got it.
And then there's also an outcome score. It's called the Knee Outcome Survey of Activities of Daily Living, basically. And that has to be a score of at least 80%. And then the last one, they have to have a global rating score of at least 60%. And all of this was basically looked at over a year. So it's not just a short time period. And then there's actually also the recommendation of at least 10 PT sessions that they should have prior to going through this as well.
Got it. So they have a little bit of a baseline from being in those for us really to get a good assessment of what's going on. My mother is one of those candidates like you, or I guess not candidates, like you were sort of talking about, someone who didn't even know that they had an ACL tear. They just had some knee pain, some knee instability. For another reason, some swelling, wound up several years ago going to get an MRI. And she wasn't exactly told by the physician that, hey, you have an ACL tear, but she was basically told, we don't see your ACL on this image, right? Like we don't see that there's an ACL still intact in your knee. So of course she's talking to me, and the longer I've been in my career, the more my family members listen to me about what they should and should not do. But, she was not someone that I recommended going to get her ACL repaired because of the activity level that she has and the things that she loves to do. She's not doing much pivoting, twisting, cutting type of activities. And quite frankly, she's probably more of a candidate coming up here somewhat soon for a knee replacement rather than one of these soft tissue type of repairs. So just interesting that you sort of mentioned that. Well, whichever one of you three wants to tackle this, I would love one of you guys to sort of talk through, when someone has their ACL repaired, ACL reconstruction surgery, overall, what does that rehabilitation process look like? Like, what are the phases of rehab? How long does it take somebody to get back to doing considerable activity? Since it's very common in soccer, why don't we go down the soccer route? How long does it take someone from time of surgery to realistically like getting back on the field, playing an actual soccer match?
Yeah, so the first thing is just setting realistic expectations and just having them appreciate, like, even if they had the same surgery, the same surgeon as their teammate, they could have a totally different outcome, and like not to like really base anything on anyone except themselves. And that's like the biggest thing, like how individualized the response is, and that educating that, like, a year would be, is still about average, but with recent studies like showing that the neuromuscular regeneration component can take up to 2 years. And so, like Adrian Peterson really kind of made trainers and PTs like pull their hair out, just coming back with like 7 months or
I think so,
and still not having any issues. And so, when that happened, then that was like, well, Adrian's back. Why am I not back? Well, because everyone is just so different. No different than any other pain response. And then like having them see, like, and then like just setting the examples like Derrick Rose, how he had a meniscus tear, and all the Chicago people were giving him flack because he should have been back at 6 weeks, 10 weeks, whatever, and he just like doesn't feel right. So just educating them on like if they're apprehensive, if they're not doing something with confidence, then that is a sign. That is a way to objectify. That is one of the things that I use when anything like, okay, but there's a reason for that. Your body's letting you know that you're just not ready for this. Whether that starts at initially putting weight on it, and how do we get them away from support like crutches, to full return to sport. If they're not, have that confidence, then that's the biggest thing that I set the stage for.
Yeah.
From there, it's just like having them appreciate, like understand the rationale for like the timelines when they start walking, when they start doing the squats, when they start jogging, when they start running. There's all rationales for those of the healing timeframes. And the challenging thing is especially with young clients is, young athletes that are eager back to sport. If they're not in pain, that is a tough one to battle. So if they understand like why they're not doing something, again, like just having them understand like this is the rationale, because those are really challenging because they want to get back to things.
Yeah. What's going on, Code listeners? Dr. Andrew Fix here. And I want to tell you about our friends at Element. Element makes a tasty electrolyte drink with everything that you need and nothing that you don't. That means the science-backed electrolyte ratio of sodium, potassium, and magnesium, and none of the junk. No sugar, no coloring, no artificial ingredients, no gluten, no fillers, no BS. And that's why I use it. I've been taking Element for 2 years now, and I absolutely love the stuff, and I wouldn't want to exercise without it. For all of you Code listeners and friends of Physio Room, Element's offered a special to you guys, and I want you to take advantage of it. Go ahead and visit drinkelement.com/physioroom. That's drinklmnt.com/physioroom to receive that special offer. You're going to get a free variety pack with any purchase that you place. And I can't wait to hear what you guys think about it. Thanks so much. Yeah, those were awesome examples. And I'm glad you mentioned those, the Adrian Peterson and the Derrick Rose, because not everybody's situation is the same, as you mentioned. And if you guys are unfamiliar with who Adrian Peterson is, of course, very well-known NFL running back, most notably spent time with the Minnesota Vikings. And then he bounced around to a couple teams, spent a bit of time with the Washington Redskins too. But, one of the more successful stories of someone who had a significant injury, ACL reconstruction, plays a very demanding position at running back, and came back really, really well, really, really fast. And that is not the typical trend that we see. I know the guideline generally that I like to give people is, I remember reading a statistic that was, if you come back to sport at 6 months post-op compared to 9 months post-op, for every month sooner that you come back to sport prior to 9 months, you are, I think it was 50% more likely to re-tear your ACL. It was either re-tear the same one or maybe it was tear the other one. But so if you come back at 6 months, you're like 150% more likely than average to re-tear that ACL. So I always give, when I'm trying to set expectations on the front end, I'm always really trying to just let people know this is going to be at least 9 months, because I don't want you to re-tear this. Could you come back sooner? Yeah, maybe. But we'll see how the process goes. So James, what was your experience with your repair? And of course, you're not getting back to, football or basketball like those two, but you're still getting back to quite a high level of activity. So when did you start running? When did you start, squatting with weight that you were somewhat happy with, and getting back to some of that higher level activity?
Oh boy. As I answer that, I'm going to cheat. And because I made a timeline of this on my Instagram as I went through the rehab process and all that fun stuff. But I took mine relatively slow, with the intention of having longevity through my new knee, basically. And so I had 6 weeks where I was completely non-weight bearing on the right side. And at that point,
meniscus repair.
Correct. Yeah. So, at 6 weeks, literally day of 6 weeks, I started walking again, but that was really the only loading that I did for a little while. And then I took things relatively slow. At week 17, I began running again. And then close to 8 months, maybe 9 months is when I started doing cutting again. Yeah. But being someone that wasn't going to get paid for what I was doing activity wise, like Adrian Peterson, he had financial incentive to get back faster. I took mine slow. I also had the mindset of basically being retired from competitive CrossFit after I tore the ACL. So what happened later down the road was, realistically shocking. But as soon as I could do something with confidence, like what Tim talked about, I did do it. And that I kind of got off the rails a little bit when it came to specific timelines that are generally seen in a physical therapy clinic.
Yeah.
I was trying to push the envelope as much as I could while still having the confidence and still understanding where my body was at in the recovery process, and not pushing it too far. And that's just a little bit about who I am. So I do think that the patient and their mindset going into recovery is huge in playing into how fast they come back and how successfully they come back.
Yeah. I love that. And of course, everybody's procedure is different, whether there's, meniscus tear, MCL involvement, just the ACL, whatever that might be. Now you started to mention some of these things, like when you had confidence, you wanted to start to push things to the amount that you could and that you felt confident with, but you didn't want to overstep and, push too much too soon. So Allie, what are, with some of the clients that you've seen and some of the surgical postoperative protocols and things that you've worked through, what are some of the very common like do's and don'ts that we see on those things, like things that people should avoid early on, things that they are okay to do? Like what can someone expect after they have one of these operations? Like, what their process is going to look like in PT in terms of you can do these things, you can't do these things.
That's a great question. So it really depends on the patient, honestly, specifically. And I really will load them and work with them depending on what they can tolerate. So to me, every patient differently. Even though the protocols will have a foundation of timelines, it really honestly depends on the patient. If they're still having trouble with a simple just air squat and they have pain, especially getting closer to that 90 degrees is definitely challenging in the beginning phases. So I'm not going to load them right away. But then on the reverse side of it too, is I feel that there is an underloading in regards to PT. So depending on where they're at and depending on pain, obviously are very big variables, but then it's also important that we're training them specifically for that sport. And I find that most patients will spend a majority of time without actually lifting a barbell or dumbbells or anything that's a challenging weight for them in regards to actually challenging them in terms of strength and hypertrophy, and not just like, oh yeah, I did, 3 sets of 10. Am I done? What's next and what do you have for me? They should be challenged and they should be progressed appropriately. Yeah.
Tim, what do you have to add to that? And then we're going to expand a little bit more on the conversation Allie just started there about, maybe not doing quite enough for what the person needs to fully get them back to things. But, anything else to add to that, like common do's and don'ts after this type of a procedure early on during that rehab process?
Yeah. So, there's, certain limitations that you are going to be before 3 months as far as like running an impact. But ultimately it is kind of an objective based progression. So like Allie alluded to, like you got to get range, you got to get strength, you got to get like balance back. And so, I've seen clients where they're 6 months out and they still don't have like quad strength, hamstring strength that is relatively close, 50% of their other side. And so they're kind of frustrated. But again, as long as you've like prefaced that from the get-go, like, hey, this could be, different for you, then that's the main thing. I just tell them like the first 6 months after surgery, you're just focused on getting strong because it takes so much longer and the patience required is so much more than anyone is really educated on typically, or they anticipate and, see headlines or whatever, see, like NFL, they see, okay, so-and-so's back after, last season and okay, well, I should be back good too. And so they just we just got to work on just objectifying their progress and not really worrying about the time frame so much, and kind of get away from that mindset that at week 12 or whatever I should be doing this. It's okay. Well, once we establish this objective criteria, then we can move on. And so then they kind of have something to focus their energy towards. Like, okay, here's my goal, and then once they get that, here's my next goal, and and then a good program is going to help them outline that so they can plan ahead and see like, okay, I'm making progress. And then, I'm not going to do this until I do, meet this criteria.
Yeah. Check these boxes first before you move on. And I have not, fortunately, haven't had the experience of tearing my ACL, but I have had several other pretty significant orthopedic procedures done. And if, I know one thing that was challenging for me was, I had this procedure. I've had 4 hip, labral, and FAI, outpatient procedures done. And then I had an ankle bone excision, had a bone chip taken out of my ankle. And during that time frame when I'm like on crutches, unable to do a lot of the things that I like to do, unable to be as active as I want to be, I remember for me, like my whole lifestyle changed. Like when I'm active and feeling healthy and exercising, my desire to eat better, get more sleep, all this stuff is naturally like a little higher. My motivation is there because it's fueling me to do those things. Man, I remember when I was on crutches, I'm hanging out at my parents' house, doing a whole lot of nothing, just laying there with a continuous passive motion machine on my hip and a ice circulating type of machine. And I'm like, hey, Mom, can you bring me a couple cookies there from the kitchen? So those are some of the things that I like to try to work on with clients in the early stages of rehab, when we know we're not going to be able to get that creative in the clinic. Like there's certain things we can do. There's certain things that we just can't do yet. And while the rehab might not seem as fun and active as these later stages, there's a lot of stuff in that person's life that can impact their potential recovery that we can work on. Like, what's your sleep? What's your involvement with the team? Are you still going to practices and like being around the group, being part of the team, like keeping that kind of motivation and energy high? Or are you just hanging out at home, not doing much? What are you eating like? Because of course, what you're putting in your body is what your body's going to try to use to repair these tissues and repair your strength and hypertrophy and all this stuff. So that's where I always like to put my focus early on, so that hopefully we establish really good habits, if they weren't already there, for when we get back to this higher level activity towards the later stages of rehab. Well, we already have that foundation set, just like hopefully the foundation of quad strength, hamstring strength, hip strength, all this stuff that you guys started to mention. Now, Allie, you started to open up this rabbit hole here of underloading in physical therapy. A lot of times I think this is a problem, not just in ACL scenarios, but just in general. We'll just say there's no profession in the world that's perfect. We definitely don't do everything perfect in the profession of physical therapy. But what do you typically see specifically with people who have had their ACL reconstructed? Are some of the common, like, I don't know if errors is the right way, but like some common things that are like, we're falling short in physical therapy with these individuals, truly helping them get back to like where it is that they need and want to be? Because we know we see a high rate of tears on the other knee. We see a high rate of re-tears. Like, how do we fix this problem? Where are we falling short?
Yeah, so I think the biggest piece is honestly education, and even just getting into different sporting teams and clubs and athletes around the area, because there's actually so much evidence in terms of actually being able to have a foundational program to help them specifically with how they're cutting, how they're pivoting, landing mechanics, all of that stuff that leads to them having an ACL tear at some point. So if we can build a program that has foundational strength and help those athletes become stronger in their sport, I think that will help immensely in terms of preventing ACL tears.
Okay. Yeah. So you're sort of saying more from the front end on the programming strategy and talking about this more from a prevention aspect of how can we get less tears in the first place if we put the right measures in place on the front end. What do you think, James? What type of, I didn't even ask you this. I know you said you had a great home gym setup and it sounds like you did a lot of your exercise on your own. Did you also attend, traditional like physical therapy or rehab at a facility? And did you see any sort of shortcomings or things that you were kind of left like wanting more from your experience at all?
Really good question. I did start PT post-op. I forget how far out, but it was probably within the first few days.
Mm-hmm.
I was starting very slow, mainly just trying to regain range of motion, specifically extension first, flexion second, quad activation, the usual things. Now although I was at an in-network facility, I think I got really lucky with the PT that I was working with back in Kansas City. His name's JT Christensen. So if you're in Kansas City looking for a great post-op, pre-op doc, that's who I would recommend. He's at SSOR. Anyway, he very, very much understood what I did and allowed me to kind of explain the things that I was trying to get back to, what was important to me. And he kind of tailored a lot of what we did to fit what was going on and what I was trying to strive for. and luckily didn't push back on me doing the things that I was doing at home. Like I, as soon as I was weight bearing again, I was back to deadlifting pretty much the exact same day, and trying to squat to depth as soon as possible as well. If you're curious on what those timelines look for me, you can hop on my Instagram page. I documented a whole lot of stuff. But yeah, I definitely did, but I used my own knowledge on the background and the back end side of things to get myself back to moving as soon as possible. Because like I said before, if I could, I did.
Yeah. Yeah. Why does this not surprise me that James was back to weight bearing and James was back to deadlifting? So, knowing what I know about you, that doesn't surprise me at all. And I'd be right there with you. All right, Tim, let's just round this conversation out kind of with you. And what have you seen? Are you seeing that when people traditionally or on average, they're wrapping up physical therapy, and I put that in quotes because, physical therapy means a lot of different things to a lot of different people. Like, are people completing or being discharged generally from physical therapy and they are ready for that? Like they're fully back to stuff that they're doing? Or I know sometimes I've seen examples of people are like done with physical therapy because they can do like their normal daily life stuff, but they're not ready to get back on a soccer field or get back on a, CrossFit gym floor and do high level activities. What have you noticed?
Yeah, that's absolutely the biggest downfall is like people, will attend PT for 2 or 3 times a week, these initial few weeks. And then when it comes time when they actually need some like good guidance, some education on how to progress their program, then oftentimes their insurance coverage is out. And so they're like, well, I guess I'll go to like this trainer or, what have you. I just had a client yesterday and he's doesn't have any timelines. He's doing well. I'm like, here's the basic exercises. You're confident with this. He has, limited number of PT visits. I'm like, yeah, let's just space this out because what you're going to need is the guidance at month 6, at month 9. And that's what we want to really help you out where, and that's the biggest deficit. And I feel like that's what goes, isn't really caught so much. And so like what we're seeing is like good practice is like at month 6, 7 is doing like some objective testing. So kind of doing the hop testing that Allie alluded to earlier, but with the expectation that you shouldn't be close to 90%, 80%. We want to just show you where your limitations are. And then that way you can see like, oh, okay, I'm, especially for those clients that don't have much discomfort or they're feeling good and maybe jogging around. It's like, oh, wow, this side compared to the other side, there's a big deficit. And then really have an objective marker to go from. But with that said, that they can still like have close symmetry, but that doesn't really represent like their movement quality. And because like you talked about, like the unaffected often getting weaker. And so sometimes we don't have that baseline to go from, then yeah, they can do well at 89%, but sometimes they're just really good at compensating. So especially these athletes. So it's a really dynamic process, and it just takes a lot of like guidance and having like someone to help guide through that and show where your deficits are.
I think sometimes, and I would say maybe even more than sometimes, I think athletes, people that are athletic, tend to be the best compensators out there because we're trying to perform a task or a role on a team or whatever that is. We tend to be really, really good at compensating and just figuring out a way to get the job done. James or Allie, did you guys have something? One of you had something to say there. Go for it, Allie.
So I was going to say, I love how Tim like brought up this point on still maintaining PT through that 6 months, through that 9 months. And not only is it just the objective testing, but it's also being comfortable through a PT standpoint, as much as I love our profession, of just having the comfortability of knowing what they need to do for whatever sport they're getting back to doing. I think as PTs, we all have the general knowledge, we're specialized in stuff like that, but there's other PTs who aren't. And I am also educating residents right now through the Orthopedic Clinical Specialty Program. And when I'm mentoring with them, one of the biggest things I have noticed is their confidence with being able to challenge their patients. And so they are doctors of physical therapy. They're going to get their specialty degree, but then they're still having difficulty of knowing, oh, can I push them here yet? Should I do this? They're like kind of delaying the timeline of getting them back to the sport. So it's also the comfortability of just like having that rapport with your PT. And if you are a PT, listening to this or just wanting to learn more too, it's just about research. It's just about asking them. I ask my patients all the time if there's sports that I don't know about. Like I had an athlete that did fencing. I didn't know anything about fencing, but I had her take videos of her friends of whatever she needed to do so I could work with those movements to help her get back to doing what she loves. But it's really just, caring about your patients, and that goes for both as a PT, but then also on the patient side of really making sure that your PT understands your needs.
Yeah. I love that because, we see that, right? In whether we're talking about ACLs or anything else, we see people go receive care somewhere, whether it's from a physician, MD, whether it's from a physical therapist, chiropractor, whoever. And quite frankly, they potentially get subpar care because that person doesn't understand the demands of their activity. Nor do all providers do what you just said, Allie, and like put in the time and the effort, really it's an effort thing, to figure out what those demands and those requirements are and learn about it, right? Like you're not necessarily going to pick up fencing, but you went and researched and studied and learned about what those demands are so that you could treat that client better. And you better believe that at the very least, created a confidence in a bond and a connection between you and that person, because they probably really appreciated the time and effort that you put in to learn about something that's important to them. And that's going to go a really long way in the rehab process because they just know that you're bought in to get them better and help them achieve whatever their goals are and guide them through that process. So this is one reason why I'm passionate about and really fortunate to work with a group of individuals like you three and the other providers on our team, because we do have those experts in people's activities and sports. And if we are unfamiliar with something, all of us are going to go figure it out and learn about it and try to figure out how we can best do that. James, were you raising your hand before? Yeah, I just want to make sure we catch that before we move on. What you got for us?
Yeah, so I just wanted to share my own experience in, getting discharged. I don't remember exactly when I was discharged, but it was probably around the 6-month mark if I had to guess. But I competed locally at 6.5 months right before I moved out here. And even though I was able to compete, I was able to, hit movement standards, I was definitely still compensating and still needed PT when I got out here. Now that was before I knew Physio Room, but I mean, some of the stuff that we were doing, we would have definitely done within our walls here. But I still needed care. I was not 100%. I wouldn't even say that I was ultimately very close. I still offloaded into my left side to stay away from my right knee. Often I still wasn't to full true range of motion, under loading. I could do it sometimes, but not super consistently. So, even though you get discharged, it doesn't necessarily mean you're ready to tackle the things that you do. And we honestly see that a lot in here. I saw it yesterday with a knee replacement. So similar injury, kind of, sort of. Yep. But discharged because he hit certain measurements, certain levels that you need to hit to get discharged, but nowhere close to the opposite side. So I
saw that individual. Yeah. Yeah. And that's, I'm glad you brought that up, because that's another, compared to you, James, of course, having your own personal experience, and then you two, Tim and Allie, having probably treated a lot more clients for ACL reconstruction than I have. I mean, I've had my fair share of clients that have gone through it, but I wouldn't say a really high number. But what I have had an extremely high number of is clients who have had knee replacements and hip replacements. And let me tell you about a group of individuals who get discharged from physical therapy before, in my opinion, they really should. And, a lot of this, like Tim said, is it's insurance driven, or if it's medical system driven, or whatever that is. But I tell people, you shouldn't expect your knee replacement to you're not going to be fully back to everything and regain the strength in the atrophy from the atrophy and all this stuff. 6 visits of therapy. Are you kidding me? That's absolutely crazy. I tell people this is going to be a year until you've regained the strength that you've lost, because a lot of that strength you've lost in control, balance, whatever that is happened long before your surgery while you were limping around on this arthritic knee, right? It's not just from the surgery moving forward. So, this is something I think we see is a problem in general in physical therapy. And, whether the issue is physical therapists are lacking confidence, pushing people like Allie mentioned, and really challenging them on, pushing the bounds and trying to get them back to things and pushing them hard enough, whether it's medical system driven and the environment clinically that they find themselves in doesn't allow them the time and the space to really demonstrate their knowledge and expertise to really help those people because they're juggling too many clients, or whether the health insurance side of things places red tape and hindrances on it and really doesn't let us work with people in the capacity that is necessary to create these and stimulate these changes. But one thing, like you guys just all sort of said, a lot of times that discharge point, which I hate that word, drives me nuts, discharge from physical therapy or graduate. But it seems like it's around that 6-month time period a lot of times. But like you sort of mentioned, that's usually not the return to sport time. So how do we kind of stretch that out and make sure people are continuing those later stages of rehab things to really get back to sport? And that's a lot of times where an office like Physio Room comes in. If we didn't get to see that individual on the front end, I don't think it's a surprise or a secret to anybody listening to this show that largely we're an out of network practice, but we end up working with these people a lot of times because they didn't fully get back to where they needed to get in the traditional physical therapy office. So we end up seeing them on the back end when they're still having issues. They're still not fully regaining their strength, whatever that is, to really help them push the performance button or pull that performance lever. So it's just, we could probably talk about that all day. Tim, I would love for you to just expand just a little bit more and maybe describe one or two of these more common return to sport tests. You and Allie both have mentioned hop tests and things, but for people that, maybe haven't had this experience, don't understand what that is, could you just explain what some of the more common return to sport testing is? And then, one or two of the more common tests, maybe just sort of like describe it so that people can visualize what you're talking about.
So like I'll have like the fundamentals. Like I want to make sure that their range is symmetric. They don't have any effusion or swelling on their joint. They can do like a step down test. They can do it, 10 times with good quality of motion, good endurance, because comparative to the other side. So establish those things well, and then so then the hop testing is you'll do like a single leg hop going forward. Do typically 3 of those compared to the other side. You'll do 3 hops in a row going forward, looking and comparing side to side, and then you'll do a cross hop where you hop on different opposite sides of the line. And then so those are kind of the main things we want to do. Often we want to do some strength testing as well. So some clinics have an isokinetic machine, most don't. So you can use different measures like functional measures as far as like a step up, like to fatigue and comparing the other side. You can use a handheld dynamometer, which kind of measures the force pushing out and just into into a device that measures how much pressure you're putting. So you can measure your quad strength as well. And am I forgetting one, Allie?
Well, those are all good ones. And then either one of you could absolutely please jump in and answer that. Now, typically, if you're going to give someone the clearance to go back to sport, are you usually looking for about 90% of what the other limb is, or what's sort of your guideline there that you're shooting for?
I think like initially it was kind of 80 and 90%. And now with like research highlighting how like the unaffected can become like atrophied and weaker, then and we're still with the high prevalence of ACL tears, then a lot of like practitioners are looking at more like we want like 100%. Like personally, I would want to be at 100%. I want to be like good enough. Knowing what I know and seeing what I've seen, like I would be in no hurry, regardless of what sport, and just knowing I want to have 100%. And the other test I forgot is just like is the SANE score. So taking into account the psychological readiness, kind of like Ali alluded to, like that is huge. Just seeing that correlation of like if where you're at before your injury, if you're 100%, where are you at now? Or sometimes I'll just say related to the unaffected, but where are you at now? And if they're anywhere like less than 90 for sure, then that is just a big red flag. And they can have like the best movement and symmetry, but if they don't have that confidence, then again, they have to have that. And so you're not always going to get that with like the objective testing. So it's where kind of the good training as far as understanding what the demands of their sport are and how can we simulate that in their rehab. So we got to have them have mass confidence. So, if they're jumping up in the air and then they get pushed and they're next to a sideline on a nasty field that's maybe wet, they got to have like maybe that exposure, that like neuromuscular control, that just kind of awareness that, oh, I can do this. They don't have to brace with a stiff knee and then be predisposed to a re-injury.
Yeah, I think that part is huge. And, having that psychological piece and being very confident where you're not going to hesitate, you're not going to hold up, you're not going to, flinch in the actual moment where you have to make that cut or that twist or pivot or reaction, whatever that is. Obviously, sports are very reactionary. I actually heard James having that conversation with a young client yesterday. They didn't tear their ACL, but they're having knee pain and they're talking about playing football. Well, I heard James tell him, if you're not feeling 95%, not 94, but 95, where you're going to be able to do something on the field and not hesitate whatsoever, I don't want you to go on the field and try to play fully, because the chances that you either continue to hurt your knee or hurt something else go up in that scenario when you're pulling up, favoring things, whatever that might be. Allie, have you seen I had this experience happen once in the clinic where I had to, talking about challenging clients, I had to really call somebody out, and it was a safety thing, right? I had a young student athlete who I was putting them through some return to sport criteria testing, some of these hop tests and things that Tim was talking about. And I really got the suspicion that they were basically like sandbagging their test, right? On the leg that wasn't injured, they were not given their full 100% effort to make it look like they were closer to 90% than I really thought that they were. Have you ever had that experience happen? Or how do you navigate that, basically? If that were to be the case, how do you make sure that the person is really putting forth full effort on their uninjured limb to really tell, is this 90%? Is this 95?
Yeah. I mean, objective testing is going to be objective testing. And that's why I think that just the education and knowledge base of the PT side is super important, because even if they do get close similarities between the two, it's all about practicing the drills and watching their landing mechanics and stuff like that following. So if they're still not able to plant on that leg or do transitions or change in direction quickly, and they're still lacking the confidence or stutter stepping or stuff like that, I'll tell them right then and there that I don't want them doing those types of things yet. So I will say and preface, before any sort of the testing of like, okay, that's awesome, you're getting closer to that, but we still need to see sport specific testing. And that's ultimately going to be the truth of everything. Because they can't fake that. If you're going game mode, you can't fake that.
Yeah, absolutely. It basically sounds like you're telling me, the objective testing is, obviously it's objective. It's sort of like the the quantity aspect of things, but there's a huge quality component as well too. There's a huge quality control situation going on. And that's where the expertise of the providers like you three come in to really be like the final judge on whether that person gets the stamp of approval or not. Man, this has been fun. What, do any of you three have something that maybe we haven't touched on yet that in your ACL experience or just PT experience in general, you really want to make sure you share with people who are spending their time with us, tuning in to listen to this episode of The Code?
Well, one thing is like, even if they kind of pass everything or objective, they can tolerate all the demands they need to, then even going further than that is like, as they transition back to sport, is think about the acute versus chronic load, and like monitoring that. And I was thinking about that. I was like wondering, James, like when you went back to lifting, like say you could do a workout and you're pleased with that, did you have to like, back off like when you would have pushed more for like subsequent days, subsequent workouts?
Oh, good question. Not necessarily back off, but I was very intentional about how I built up. So, in CrossFit, you hear the RX and scaled mantras, if you will, versions of workouts. I did a lot of scaling and modifying to make sure that I was able to move well, and generally without pain, before like really pushing the pedal. Now, there were times where I would ultimately stop a workout short because of the fact that I didn't feel comfortable or realistically safe doing something. But I never stopped myself from trying necessarily.
Yeah. I like that. That's a good question, Tim. And I think, the idea that you just mentioned, James, whether someone's had an ACL reconstruction or not, I think is just a good mode of practice anyways. Like if you're training or you're doing a session, you're doing something and something's just not feeling right, it's probably a time to be very aware of that, potentially modify things or get the extra set of eyes from a coach or whatever that is, whether someone's injured or not, if your movement quality is going to sacrifice potentially putting you at risk for some sort of an injury. No, this has been awesome. The only other thing that I wanted to mention, and then if something comes to the mind of you guys, please chime in, is we sort of talked about a lot of times traditional physical therapy or rehab is, falling short on loading people. They're completing physical therapy sooner than they probably go back to sport safely. Is, whether you're someone who's had an ACL or someone who does, or like Allie's sister going through this process right now, is you have to have a really good network of individuals who are resources around you that you trust to have your best interest, at heart type of thing. Whether this is coaches, trainers, athletic trainers, rehab specialists like us, people who are going to make sure that you're progressing on a timeline that's appropriate for you and you're not putting yourself in, further harm's way to potentially re-tear or tear the other knee and whatnot. And it all starts, like Allie said, back at the prevention side of things. A lot of times we get to talk to coaches, whether this is of soccer teams or lacrosse or whatever, as a byproduct of we're treating one of their athletes who has already had an injury, right? But if we could have those conversations on the front end, put injury prevention programs into place, put very thorough and adequate warm-up, cool down procedures in place, make sure strength and training programs to complement what they're doing on the field is very sufficient to potentially try and prevent these things in the first place. That's going to be the best place to start to, sort of tie in or wrap up this whole, I don't want to lightly use the term pandemic, but issue of ACL tears being so prevalent and continuing to rise every year, especially as we see, sport specialization and things happening, the numbers not going down. So.
No, that's an awesome point. It doesn't matter what sort of program rehab is, having that relationship and that alliance, because where I worked at before, I'd have 40 or 50 clients a week, and following up with people that could use some more guidance or really being able to establish a good relationship was compromised in that setting. Whereas now it's just great to be able to work one-on-one for an hour and then not have that client load, and so then people making that relationship, and then they're much more ready to reach out to me if any questions, and then we can communicate so much better. And so like you touched on, that is just a huge part, is having someone they can bounce ideas or questions off if something's not feeling right.
Mm-hmm. Mm-hmm. For sure. Any closing remarks, James, Allie?
I guess I would just add that, you're not as delicate as you might think you are post-op. As long as you, clear those first full handful of loops to jump through when it comes to structural integrity and stuff like that. As long as you keep movements clean and you are within the boundaries of realistically staying outside of impact and rotation, typically speaking, you can kind of, you're not as delicate as you might think. And then just a big piece, prehab is huge. Get as strong as you can, as fast as you can, right before you get that surgery. I I worked out the morning of my surgery. Whether that changed anything or not, I don't know, but seemed like a smart thing to do. And I also deadlifted every single day for like 45 days pre-op as well, because I couldn't squat. So I was just trying to move as much weight as I physically possibly could. So get as strong as you can. And you're not delicate. That's all I'd say.
There you go. What do you got, Allie?
My biggest piece would be like, if you're a PT that's listening to this, just always be curious, always be willing to learn, and find a mentor, reach out, ask questions. Don't be scared to ask silly questions. I love that my residents ask me questions because it's going to challenge myself, and that they're curious because they want to be better PTs. So I love that about them. And then from the patient perspective, day one and even through your first month, it's going to be a slower process. So really get to know your PT, really make sure that you can build that rapport, because there's definitely a high percent. When I say high percent, 25 to 45% of patients that have ACL surgery will not return to the sport anymore just because they're fearful and they're scared to get re-injured. And so having a PT that's going to listen to you and understand your concerns, you want to be able to be open with them, hear their concerns of just daily struggles to help them get through, because they're going to be the ones that are going to help you through the confidence through the end phases. So those are my kind of final pieces that I would say from both perspectives.
Yeah, I love it. I love it. And I think that's an awesome piece to close on there. Those of you that have listened to other episodes of the Code before, you know that if you ever need guidance, support, someone to listen to you, please don't ever hesitate to reach out to us. You'll find all of our contact information wherever you found this podcast. And then you'll find the information for Doctors James, Tim, and Allie in the show notes, whether you want to connect with them on Instagram or Facebook or email or whatever that is. Please feel free to reach out to us. And then if you're somebody tuning into this show who doesn't live in the Denver, Colorado area where we are, we work with people virtually. We have a huge network of other providers that we trust, just like some shout outs James gave in the Kansas City area. We know people all over the place. If you need someone locally where you are, we can give you some guidance and some support. So thanks again for tuning into this episode of The Code on ACL reconstruction, and we'll catch you guys back here next time. Thanks so much.